Good morning. Welcome to the webinar series on COVID-19 and novel infectious diseases, hosted by the Policy Research at Hong Kong IAPS. The COVID-19 pandemic has affected the world for over a year. The pandemic is drawing tremendous global and local attention, not only to medical and epidemiological research, but also to interdisciplinary research in behavioral and social science that inform policies. Unprecedented city-level and national-level lockdowns have given rise to challenging political, economic, and social psychological policies affecting people from all walks of life. Quarantine, wearing masks, and social distancing have almost become common requirements around the world. Yet, adoption, compliance, and effectiveness vary across jurisdictions. Governments are rushing to speed up vaccination programs with varying take-up rates. The economic downturn and strain on the healthcare system pose dilemmas to policymakers. Misinformation and erosion of public trust threaten good governance. The fallout caused by this pandemic and future novel infectious diseases will bring continuing global challenges. We have a lot to learn from the responses to the pandemic. More up-to-date and evidence-based academic research grounded on empirical scientific evidence is badly needed for public policy reference. The CUHK Policy Research at Hong Kong IAPS program was established to promote cross-boundary and interdisciplinary collaboration on policy research. We are pleased to present a series of webinars to share the works of our researchers across different faculties on issues related to the pandemic with implications on policy decisions. Our webinar today is on integrated vaccination and physical distancing interventions to prevent future waves of COVID-19. In this webinar, the speakers will share the latest research related to the following subjects. What is the estimated outcome of vaccination combined with physical distancing and stay-at-home restrictions? Does population density have any effect on integrated vaccination and physical distancing interventions? Our two speakers are Professor Huang, Professor, Department of Geography and Resource Management at CUHK. The second speaker is Professor Paul K.S. Chan, Chairman and Professor at the Department of Microbiology, CUHK. And our discussant will be Professor Martin Wong, Professor at the Jockey Club School of Public Health and Primary Care at CUHK. Our two speakers will speak first, followed by the discussant, and then we will allow for Q&A session. Meanwhile, please send your questions to our chat box, to our administrator in our chat box, and we'll invite you to raise your questions during the Q&A session. First, our first speaker is Professor Huang. He received his PhD from the Chinese Academy of Sciences. His research focuses on most aspects of GI and GI science. His devised model of geographically and temporally weighted regression has been widely applied in different areas, including economic, ecology, urban planning, and so on. This model has also been adopted by industry to support various smart city applications. He serves as the editor for International Journal of Geographical Information Science. Please join me in welcoming Professor Huang.
I'm very pleased to be here to represent a group of researchers, including Professor Paul Chan, Tony Tam, and Ying Huang, to present our research work on the integrated vaccination and physical distancing interventions to prevent future COVID-19 waves. This presentation is based on the paper we have published in Nature Human Behavior, and I would like to take this opportunity to thank all the co-authors for their contributions to this work. A little bit about the background of this research. COVID-19 was first reported in late 2019 in Wuhan, China, and has since spread extensively worldwide. As infections decreased during the summer months last year, many countries relaxed their lockdown and physical distancing measures in the course of reopening their economies and societies. Due to the increasing mobility and social contact rates, accompanied with large numbers of susceptible people and hidden cases in the population, these countries experienced COVID-19 resurgence. In the absence of vaccines, physical distancing, for example, closure of schools and workplaces and cancellation of large gatherings, and other non-pharmaceutical interventions, NPIs, are critical to stem the resurgence. But people are fatigued by physical distancing restrictions, and policymakers look forward to more supplies of vaccines so that more people can get vaccinated and physical distancing can be alleviated. But to what extent physical distancing can be alleviated is still unclear. So more comprehensive interventions, including both physical distancing and vaccination, should be developed to avoid COVID-19 resurgence. To this end, it is important to understand the interrelationships among mobility, social contacts, physical distancing, vaccination, and virus transmission, so as to inform public health policy making. Human movement and contact rates play important roles in shaping the transmission patterns of infectious diseases. And many studies have been conducted to investigate the spread of COVID-19, for example, from Wuhan to other cities, using anonymized mobile phone data. And in the follow-up studies by others, mobility data generally serve two purposes. One is that it measures to what extent people adhere to government's physical distancing interventions. And in that sense, mobility serves as a proxy of the intensity or level of physical distancing interventions. Another purpose is that mobility has been used as a proxy for reopening. For example, high mobility indicates high level of reopening, and low mobility indicates low level of reopening. But mobility hasn't been explored to directly measure social contexts, which are actually essential to inform the transmission process. More importantly, mobility hasn't been attempted for assessing the effect of individual interventions to inform disease transmission, and our research intended to address such issues. We made use of Tencent check-in data, which are actually anonymized aggregate data in this study, and this data is contributed by more than 1 billion users, which covers more than 70% of population in China, and the land use category is assigned to each grid cell in the check-in data. And here is a mapping out of the check-in data over entire China. Different from the traditional social contact data that are obtained through conducting interviews, we tried to derive the social contact data directly from mobility data. And in our context, social contact or contact refer to the spatial temporal co-presence of any two mobile device users. Let's see a close-up view. So this space-time cube represents a city or part of a city, and this ellipse represents a residential zone. This vertical straight line indicates that the person may stay at home, And this polyline indicates that the person may go outside of his or her home to meet up with others, leading to a spatial temporal co-presence within a space-time being. This indicates a contact occurs, leading to one time of contact. So we use such a method to derive social context in terms of the mobility data. And the previous studies indicated that mobility alone can measure the intensity of physical distancing. However, from this figure, you can find that these two cubes are at the same mobility level, but they have different levels of social context and hence different intensities of physical distancing. So only mobility and context are used together, which can determine the intensity of physical distancing. The mobility alone cannot achieve that. So this is the framework of our research, including two parts, the data part and the modeling part. So we use the mobile device checking data to derive the total social contact index, or TSI, for the entire city, divided by the number of total ambient population. Then we can derive the SCI, social contact index, that's the context per person. Then we use such observed data to validate and model the mobility SCI relationship. And this model is linked to a mobility contact susceptible exposed infectious recovered model to conduct scenario-based simulations. And in our simulations, we consider different types of interventions such as stay-at-home order, physical distancing, vaccination, mobility restoration in reopening, and population density. And this framework is used to assess the effect of individual interventions or a combination of different interventions. And this figure shows change of SCI in Wuhan during the pre-lockdown, lockdown, and post-lockdown period. And after the government implemented the lockdown measure on January 23rd, 2020, then we saw a drastic drop of social contacts to 2% of the pre-lockdown level. And after 76 days lockdown, the government decided to lift the lockdown. And this is actually after 2 weeks of mobility and social contact recovery. And this indicates the government was so prudential in reopening up the economy and society. And here you can see the proportions of social contact index allocated to different land use categories, such as workplace, schools, shopping, recreation, residential, community, etc. And such data are used to derive social contexts in such land use areas. Based on the SCI changes in Wuhan, we can discern 4 periods, namely pre-lockdown, lockdown, shortly after lockdown lifting, and longer after lockdown lifting. And in different periods, a different intensity of physical distancing were implemented. And according to different intensities of physical distancing and a different level of population density, higher, medium, and low, we devise the different mobility SCI relationships. So given a mobility level, population density level, and the physical distancing intensity, then we can estimate the corresponding SCI to inform the transmission process using SEIR model. And this mobility SCI model has been validated using the actual mobility SCI observation. And you can see the Pearson correlation can reach more than 90% over the 4 periods. And we reconstructed the transmission process in Wuhan using a SEIR model. So you can see here the simulation of the new infections agree well with the reported cases in Wuhan. And to show that YSCI can explain better the transmission rates in Wuhan, we calculated the quantile nonlinear correlation between the effective reproduction number, RT and SCI, and that between RT and mobility. So you can find that the nonlinear correlation coefficient between RT and SCI is 0.59, which is much higher than that between RT and mobility. This indicates that SCI is more strongly rank correlated with RT than mobility. That's also explains why we use SCI instead of mobility in our simulations. To contain possible resurgence in future, we simulated a scenario on the different physical distancing intensities, mobility levels, and population densities. And here 30%, 50%, 100% of population density in Wuhan represents low population density cities, medium population density cities, and higher population density cities. And here we have different intensities of physical distancing and different levels of mobility. And the DCR represents the median duration to contain the resurgence. And you can easily find that the stay-at-home order mobility reduction and at least a moderate physical distancing are required to stem the resurgence. And cities with higher density require stronger physical distancing. And even with the same level of mobility reduction, for example, here you can find that the duration for containing the resurgence in higher density cities require 259 days, which almost triples the duration for medium density cities and almost 4 times of for the low density cities. We also simulated the resurgence with vaccine available, and we consider several aspects in our scenarios. So the period is for 1 year, and the herd immunity threshold is 64.2, so which is calculated based on a number of R0 values derived by other studies. And we also consider the effectiveness of vaccine, which could be 50% for the pessimistic scenario, 75% for the neutral scenario, and 100% for the optimistic scenario. In addition, we also consider the loss of antibody. And for the recovered people, the fighting rate of immunity is 6.12 with reference to the SARS data because no data available for COVID-19 vaccines. And for the vaccinated people, the fighting rate of immunity is 53.05 within 1 year with reference to the data for the influenza vaccines. And the interval between first dose and second dose is 42 days. So after 40 days of injecting first dose, then the immunity can increase to 100%. And we use such data in our simulations. And in the simulations that combine vaccination with physical distancing to contain the resurgence, we consider different population densities for cities. And in the case of low population density, the physical distancing and stay-at-home order would no longer be needed. And for the medium population density cities, and even mild physical distancing can stop the transmission in such cities. And this, however, cannot be achieved without vaccination. And here, reduction rate represents the comparison between applying physical distancing and not applying physical distancing. You can see that in the case of using vaccines, if we apply physical distance, then it can significantly reduce the infection rate. And for higher population density cities, the moderate and strong physical distance will still be needed to reduce the case number. And the physical distancing can be used solely to contain the resurgence without stay-at-home order, without mobility reduction. We can achieve the purpose of containing the resurgence. This indicates the vaccine is so powerful. And we also simulate the scenarios with different effectiveness of vaccine. And under low and mild physical distancing applied, the effectiveness of vaccine makes a much difference in reducing daily new cases. But with moderate and strong physical distancing applied, the different effectiveness of vaccine does not show much difference in reducing the daily new cases. So in conclusion, we have developed a tool for assessing the effect of individual interventions. And this method can also be applied to the evaluation of other public policies. Actually, it's a generic approach. And vaccination in combination with physical distancing can suppress resurgence without relying on stay-at-home restrictions. And on the way to achieve herd immunity, cities with a higher population density require more stringent and long durations of physical distancing. And containing a resurgence in the absence of effective vaccine is a costly process, especially for cities with higher population density. So when the vaccines become available, it is important to improve the uptake of vaccines. Only use vaccines we can curtail the pandemic. By the way, just for your information, we are conducting a project on assessing and implementing non-pharmaceutical interventions to avoid COVID-19 resurgence using both big data and small data under the support of Hong Kong RGC's collaborative research fund. And hopefully we will have more interesting results to report to you later on. Yeah, that's all. Thank you very much.
Thank you, Professor Huang. We really look forward to your next CRF grant result. Our second speaker is Professor Paul Chen, Chairman and Professor at the Department of Microbiology at CUHK. Professor Chen received his MD from CUHK. He's a renowned clinical virologist of a special interest in tumor virology, human respiratory viruses, and microbiomes. He serves for many key professional bodies in Hong Kong, including on the Scientific Committee on Emerging and Zoonotic Diseases of the Center for Health Protection. He's also a partner of the Global Outbreak Alert and Response Network. Please join me in welcoming Professor Chen. Paul, over to you.
Thank you very much, Professor Cheung. Very kind introduction. It is my great pleasure today to share a talk with you. And the study I'm going to present actually is also led by Professor Martin Wong. He is also with us today as a discussant. So I'm going to talk about vaccine acceptance, the situation in Hong Kong. Now, 2 years ago, before COVID-19 appears, the WHO predicted 10 global health threats, including air pollution, climate change, antimicrobial resistance, dengue infection, Ebola, HIV, those deadly viruses. And just mind you, one of the 10 predicted global health threats include vaccine hesitance, which means when vaccines are available and become effective and safe, but people are still very reluctant to receive it. So this has been an impact on the control of a number of infections, measles, poliomyelitis, and even cancer, because this is cancer caused by a virus that can be prevented by vaccination. So obviously nowadays, people would like to know how vaccine hesitance is impacting on COVID-19 pandemic. So as of today, there were a number of COVID-19 vaccines available and licensed in a limited way for public use. And at least one of the vaccine came into a safety issue and now temporarily stopped. So there seems to be not a very smooth roll in the rolling out of COVID-19 vaccine. First, I would like to share very briefly a paper published in Nature Medicine. This is by a group in the US. And the study was conducted in June last year, before the vaccine actually available, and involved 19 countries. Basically, they asked a question: if COVID-19 vaccine is proven safe and effective and is available, we will take it. So the answer roughly is that for countries like China, Brazil, South Africa, South Korea, they receive a high intention to receive the vaccine, ranging from 80 to almost 90%. Whereas other countries like Russia, Poland, France, and Nigeria, belonging to the lower end, starting from around 50% of people will say yes, they want to receive. So globally, the acceptance is like around 50 to 90% at June last year. So obviously, we want to know what happened to Hong Kong, although we are also part of China, but we may or may not share the same attitude towards acceptance for COVID vaccine. So our team conducted a study to look at vaccine acceptance in Hong Kong. So just wind back the history, we have four waves of COVID epidemic in Hong Kong. The first one was a very small outbreak, and then the second wave, the third wave, and now we just passed the fourth wave. Our study was conducted last year in end of July to August for about 4 weeks. That was at the third wave when we have a very severe attack of the COVID-19 in Hong Kong. I still remember the first day we started the phone survey, it was about 100 cases per day, and that was the record at that time in Hong Kong. So at that time, the society was very alert and maybe nervous. We are practicing work from home, mask in public place, maximum 2 people outdoors, school closed, restaurant closed, and a lot of social distancing measure at that time. So the survey was based on telephone interview. We target adult 18 or older, and for each household, we allow 1 member to receive the survey, and we conducted during the evening. So initially, we target about 1,000 people, and assuming 50% will accept, and then we have a precision of 3%. So after 4 weeks, we completed the survey, and actually the questionnaire was designed by epidemiologists, psychologists, and clinicians. And the key question to start with, if Hong Kong government provides 3 vaccines within the coming 12 months, will you receive it? Okay, and yes, no, and not sure. And then we link it with other variables covered in 55 questions, including social demographic characteristics, health conditions, quality of life, health belief model, and also the trust to health system, and also the vaccine technology and the manufacturer. So basically, this is the health belief model that we use to construct the questions. We measure the perceived threat, asking whether you think you may be susceptible to infection in the coming 12 months, and whether you think you may have a severe infection if you caught it. And then the outcome, we ask whether you think the vaccine can protect you, and also the barriers, whether you think the vaccine is safe, side effects, and also physical barriers to those vaccination centers. And we also measure the cues to action, so that whether the recommendation is coming from government, doctors, family, friends, how do they different? And then we finally try to model whether they accept vaccination, and how strong are these facilitators and barriers to their acceptance. Okay, trust. We measure the trust to healthcare system using 3 questions, and also the trust to manufacturer who may not have a previous record on producing vaccine, and yet they are producing it. And also the new technology for like the mRNA vaccine, DNA vaccine, and also the country of production. We didn't say whether it's China or not, we just say country, but we think this may be important measure in terms of the situation in Hong Kong. And then we ask if there are a certain number of people in the clinical trial receive the vaccine, whether you think it is large enough to give you a reassurance. Okay, after 4 weeks of telephone survey, we completed 1,200 surveys, and we got a response rate of 55%. So I think this is quite encouraging rate. And majority of our respondents were age 55 and above. Most of them were female and married, and 70% are of secondary or lower education. And 1/3 are retired, and 1/3 are housewife. So I think this is important to understand the limitation of our study. Okay, acceptance for COVID-19 vaccine. So the crude vaccine acceptance rate, that means the proportion saying yes to our question, is 42.2%. And as I've shown you, we have some bias in age distribution. So after weighing, then we estimate the overall adult population acceptance rate is around 37.2%. So this is the breakdown on the age-specific predicted vaccine acceptance rate in Hong Kong. So you can see for the very young, they have 40%, and then decrease a lot for the working group, and then going up with age. Average is around 37.2%. So to summarize our result, I think the first message we can see is that we have a pretty low predicted acceptance for COVID vaccine, only 37.2% of the adult population. This is obviously not enough to build herd immunity, and not enough to relax containment measures. And also it will be a very bumpy recovery for the economy. So compared to overseas countries, we are well below even the lower margin of Russia, for example. So this acceptance rate could further decrease when the vaccine is really rolled out, because we are aware of that there are studies in Hong Kong showing that the acceptance rate actually decrease over time. So of course, we need a strategy to improve vaccine uptake. Okay, here are the major results on the odds ratio for different variables in associated with vaccine uptake. And these are based on multivariate analysis data. So we find that the chronic illness has an association, is a driving force. And the health belief model for most of the components, you see a positive association. And the cues to action also you see a positive association. And the trust also you see some association. But I would like to point out a few of them for our attention. So the second message from our study, I would say, is this one. So if we look at the perceived barrier and the perceived harm as a barrier to vaccination, they both barrier to vaccination, 0.8 and 0.77. And I want to point out that these two factors are very, very similar. And You may think most people do not receive vaccine because they are afraid of side effects. But in fact, apart from side effect, we do have other barriers to vaccination, which is a little bit even stronger than the afraid of side effect. And if we further look at the age distribution of acceptance, so you see this working group of people, age 25 and above, they have the lowest acceptance rate predicted for the Hong Kong population. So we think in addition to promoting vaccine is effective and safe, we do need some incentive, especially for the working class. For example, travel allowance, paid leave, certificates, and so on. So this incentive is probably necessary for Hong Kong. So message 3. Another point I would like to draw your attention is the facilitator. Okay, the perceived susceptibility is actually not significant in our measurement. And then the perceived severity of the disease shows a little bit effect on driving vaccination. Now, I think in Hong Kong, people in Hong Kong, they do not aware that they may be susceptible to COVID-19 vaccine. Perhaps because in Hong Kong, we actually do not have a very high incidence compared with other countries in the US, in the Europe. Also, our mortality is not that high, which is a good thing. But for vaccination, people become too reassured that COVID-19 may not be too severe. And that's why they do not like to take vaccine. So I think education on the true health impact is necessary so that they understand what is the true impact of COVID-19 infection. So the fourth message I would like to highlight, perhaps is this one. So recommendation. So who is going to be the driver to recommend vaccine? So from our study, we find that, okay, in fact, government's recommendation is very strong, stronger than doctors, family, and friends. So with that, I think the government should take this property and be the leader in recommending vaccine and find a way to persuade people to take up COVID-19 vaccine. And then finally, for the trust, we asked a few questions. First, on the new technology, would that affect your decision to take vaccine? 43% of people think that the new technology could be a concern to them. And also manufacturers that lack record in vaccine production. In fact, there are quite a number of manufacturers now involved, but yet they may have history in drug production, but not necessarily vaccine. So more than half of our interviewee does have a concern. And the country of production, 62% did look at the country of production. And also the number of people receive the vaccine in clinical trial. If it is less than 50,000, they do have a concern. And if you look at those clinical trial data, in fact, many of the clinical trial have less than 50,000 participants. Although this is enough for generating data for the clinical trial, but people may still think that they are not reassured by this number of people who have received the vaccine. And within this, I believe there are a lot of false information, such as the technology, manufacturer, the country, and so on. So I think to clarify this and to correct this false information is also a very important point in our vaccine rollout. So what is the actual uptake in Hong Kong? I think our next speaker, Professor Martin Wong, may share some data with you. So that's all on my part. And finally, I would like to draw your attention. If you want to know more about the study, you can look at this paper in Vaccine. And we have a big team of people helping out this study, especially Professor Martin Wong and Professor Eliza Wong from School of Public Health. And actually, they are the real driver of this study, rather than I just presented on behalf of them. Thank you very much for your attention.
Thank you, Professor Chan. Our discussant is Professor Martin Wong, professor at the Jockey Club School of Public Health and Primary Care at CUHK. Professor Wong received his MD from CUHK. He's a specialist in family medicine and a researcher in the field of cancer screening and the prevention of chronic diseases. Professor Wong has composed over 300 publications in international peer-reviewed journals. Apart from serving as the chairman, co-chairman, and reviewer of different organizations worldwide, he is also serving as editor for the Hong Kong Academy of Medicine. Please join me in welcoming Professor Wong. Martin, over to you.
It's my pleasure and honor to discuss on the two outstanding presentations by Professor Huang and also Professor Paul Chan as well. So for the discussions, I would like to capture the two major papers and the two major messages. So for the first paper, outstanding ones from Professors Huang, Chan, Tam, and Hong, we understand that the rationale of the paper is that mobility data alone cannot directly inform physical distancing and decrease the contact rate. And therefore, one of the major strengths of this paper is that it has successfully derived what we call SCI, a social contact index, which represents the daily average potential social contact per person. And it successfully associates the mobility level with the social contact rates and utilizing a spatial temporal co-presence of people with a very broad coverage of the Chinese population, incorporating components including physical distancing intensity, population density, and also vaccination. It is more strongly rank correlated with the reproduction number than mobility. So I think the authors have also successfully shown that the effectiveness and duration of physical distancing measures are highly dependent on the intensity of intervention and also population density as well as vaccine availability. It's the very first study that examined resurgences based on social contact pattern. So I like these diagrams very much because they can actually inform the policymakers by understanding the population density and also the mobility level. One may think about the different social distancing measure incorporating vaccination rates and coverage into consideration. And this will give all the audience and also the population a better idea of the level of physical distancing measures, which will be very valuable for healthcare providers. So there are a number of issues we've been thinking about, and also the paper by Professor Huang and also Paul Chan and collaborators have successfully addressed. So what level of physical distancing measures should be applied? Also, should we order staying at home? Can we estimate COVID-19 outbreaks? And also, what should be the disease control strategy in countries with different population densities? So I think the major application of this paper is that we can appreciate the combined effects of physical distancing and vaccination on the resurgences of the epidemic, and therefore the most effective control strategies with real-time adjustment could be made. Now, the second paper, also led by Professor Paul Chan, has focused on the determination of COVID-19 vaccine acceptance and also the relevant determinants. The strength of this paper is that it's actually based on random sampling, telephone survey, using a validated survey instrument with a relatively high response rate, more than 50%. And the probably a news which is a little bit unfavorable is that the acceptance rate was low. And then, however, this paper has explored the different variables which could be linked to a theoretical framework called the health belief model, where a number of the what we call the strong drivers, including governmental recommendation and also barriers like lack of confidence and manufacturers without any track records could be identified. And it's also the first paper that associates vaccine and also together with health belief model in our locality. I also like this diagram, and I totally complete with Professor Chan that in fact, the younger generation, those aged 25 to 34 and also 35 to 44, should be given more attention. And also the governmental recommendation is so strong, and therefore this might be a factor where we would like to enhance even further. So this paper has actually addressed on the very important questions, including what are the major concerns of the public on the COVID-19 vaccine, how should we enhance vaccine uptake rate, and also the direction of future publicity and also promotion of our vaccine. So I think the paper has already given the significant constructs and identify independent predictors which could provide evidence-based formulation and implementation of vaccination strategies. So one might probably ask, what are the other problems that we should actually pay our attention to? I think these 4 questions have been hot topics in the academic literature, where we could actually pay our attention more on their discussion. Firstly, should we lift the physical distancing measures according to vaccination? Now, as in this diagram, we can see that, in fact, even the chief executive has been thinking for a number of strategies to enhance the response rate. And then, as you can see here, according to the Center for Health Protection vaccination dashboard, only 9.4% of the general population has received the vaccine. And according to Professor Huang's paper, we have to really think about, for vaccination, how are we going to increase the vaccination rate together with Professor Paul Chan's paper, or talk about incentives. So question number 1, we can see that there are a number of advocates, including physicians, so a specialist here, and also a pharmacist. They have already recommended green card for, say, for instance, if you got vaccination, you're exempted from certain travel bans, and also you may enjoy vaccination bubble incentives, aiming to boost the jabs rate. So this sounds to be a very nice idea, and that the government has now been thinking about the different stages, where if you've been vaccinated, the employees in the restaurants have been vaccinated, then of course, more people can be seated together. Now, however, there are challenges from the community. For instance, some of the employers may push the employees to receive the vaccine, and also some of the employees might not be suited for receiving vaccine because of medical conditions. And I heard that even some of the employers think that, well, it would be unethical to fire an employee and also boost the business simply by increasing the number of people who receive the vaccination. So there are issues which will require a discussion. The second thing is really about monetary incentives to enhance vaccine rate. Should we give money? Now, from the news, we realize that because there are sporadic news talking about people dying, possibly linked to the vaccine, and also serious complications as well. And also there are experts talking about, for the second dose of the vaccine, the chance of serious adverse effects might be higher. So therefore, money actually represents the strongest driver among all the incentives. But I think the academics do not agree. Because when we go to the major journals like JAMA, Lancet, there are lots of discussions about whether monetary incentive is ethical. One of the discussion points is that, in fact, if we give money to a person who would like to receive the vaccine, the person might probably think that the vaccine itself is something bad, and therefore the government will need to give money. Another issue is that some people have actually discussed about vaccination being a social responsibility or civil responsibility. Do we agree? Not all people agree, but some people agree. So if this is a social responsibility, how come the government should spare public money to enhance something which is a responsibility? Now, the argument can go on forever, but for the sake of time, I don't think, perhaps in the discussion session, we can actually address this as well. Now, thirdly, it's really about the compulsory vaccination in certain groups, such as healthcare providers and also people at high risk of having COVID-19 infection. But people will say, well, come on, you're a medical doctor. You are serving your patients and you're seeing a lot of patients every day. So do you have the responsibility to receive the COVID-19 vaccine as a compulsory measure? So this would therefore raise a bioethics problem. Will that force people to receive vaccine, whereas some of the doctors might not be fit to receive the vaccine as well? They're humans. And then for some of the employees, they have actually some sort of this sort of threat as well. They can actually perceive it as something like a compulsory measure, which might not be very ethical. So this, well, there are pros and cons, of course. Some people might probably argue this would actually help build herd immunity. So do we agree? That's the third question. Last but not the least, I think the WHO Europe has nicely published what we call a strengthening and adjusting public health measure statement. And then in that particular statement, they highlighted some of the very important country-specific measures to control and combat the COVID-19 pandemic, such as public health and epidemiological considerations, which should be in place to consider the different interventions, and such as that the health system should have a proper governance. Questions: how about if some countries who are relatively less privileged to have these resources? How about some countries that might not have the necessary infrastructure to do it? Should we force them to do it? So my last slide is just to say that we definitely need future studies, and research gaps will be incentives, as Paul has talked about. What are the solutions to handle vaccine hesitancy? How can we identify the enablers and barriers? How should we balance social distancing, interventions, and citizen expectations? What about ethics, autonomy, and beneficence of the society because of the vaccine? But on the other hand, I lose my autonomy. Is it really acceptable? And last but not the least, I think the hottest topic now will be the mutation. And then should we receive the fourth dose, fifth dose of the vaccine? So I think the experts could tell. And once again, I wish to finish this off by firstly saying apology again to everybody, including Professor Fanny Cheung, for the technicality issues I encountered. But then, of course, I express my first sincere gratitude for this opportunity, because I think this topic is actually very, very important, and the seminar is very timely. Thank you very much.
Thank you, Professor Wong. And you have raised a number of very challenging and timely questions to the whole community. But I'd like to thank our two speakers and our discussant today, Professor Huang, Professor Paul Chen, and Professor Martin Wong. And I'd like to thank the audience also for your patience in participating in this webinar.